Yeah, but I know. I have thought
What? Good luck. It's our next Monday. It's today. Yeah, there's no. And now we come to, so our main student today. Also. Guess what? But.
Ready, make it last, okay? Yeah, you look so tan and well rested. Oh, good deal, good deal. You see ya, see ya. Okay, let's start with prayer and then talk about what's happening. We only have 2 months, people, 2 months. You know how fast the first half went. Second half goes just as fast, so we're ready. We're rejuvenated, we're ready, right? Almost, maybe. Okay. All right. In the name of the Father, Son, Holy Spirit, amen. Thank you, Lord. Thank you for getting us back safely to this place. We thank you for that break. Just a well-timed this break to be able to rejuvenate and prepare for the last half here. We thank you for that. Let's say a prayer for all our family and friends, wherever they may be. We say a special prayer today on St. Patrick's Day. We thank you for the gift of the saints in this room, but also the saints that have showed us how to love you well. So help us replicate their lives and their example. Thank you for St. Patrick on this day. We thank you for all your many gifts. Amen. Okay. Good job, Joseph. Representing. I knew my Butte man would come through. It's St. Patrick's Day, people. As you got it going on, good job. My dad was a very proud Irishman. So we represent on St. Patrick's Day. Okay, let's talk about your exam. It is on Monday, not Wednesday. Yeah. Okay, so that's good. Monday, what's the date on Monday? 24th. Thank you. Monday, the 24th. Okay. So what we're talking about today is on that exam. What we talk about on Wednesday is not on that exam. That will be on exam 3. So I want you to pay attention for both topics, but just know like what's Wednesdays is not going to be on your exam Monday. Good. Be okay with that. What chapters are they? Maybe we should find ourselves. All respiratory, maybe just respiratory, renal, ABGs. Answer. Is that all? I mean, those are topics, but you know, there's multiple. Upper respiratory, lower respiratory, infectious respiratory, renal, acute, chronic, PKD, and ABGs. Okay, awesome. Good deal, good deal. Midterm grades are due tomorrow. I already put ours in, so you'll see that. They reflect your exam score. So for nursing classes, it's always your exam score. So you don't have exams, then I'm not sure what it is, but For us, it's just your first exam. So that's good. Why do we do that? Because we don't want anyone to be lulled into like false security that maybe their grade is higher than the 75% needed on the testing average. So just take a look at that. Let me know if you have questions, but right now it just is that first exam grade. I'm not sure when advising starts, but probably in the next couple weeks. You know, once midterm grades hit. Usually shortly thereafter, so be looking for emails from your advisor about that. You will be getting ready for senior year, people. Oh my gosh, that's so cool. Okay. Also cool is we have extra credit opportunity coming up, which is a rare thing for us. So hopefully you'll be able to take advantage of it. It's Thursday night. I think at 7 p.m. in the lower comments. When it starts, Dr. I'm not
Yeah.
exactly sure how you pronounce the last name, but that's how you spell it. Dr. Campuses, I would guess, I'm not sure. He is a bioethicist at Creighton University. So that's in Nebraska. And he's coming and he's talking about us. He's talking about nursing. So he wrote a book with a nurse about kind of holistic care of the patient, which is what you were all learning, but not all programs learn holistic care. So you should know it's a little bit different than maybe people you might be working with. And then also just the ethics of it all and kind of the bioethic situations that can arise as a nurse. That's what his book was about. So I'm imagining that his talk is going to be similar to that. Yeah, so I would like you to go. We need to have good representation because it's about us, right? And I want us to learn from him and be able to ask questions and that kind of thing. So if you can attend, I will give you extra credit. And I want you to tell me the 3 things that you came away with from the talk. Okay, 3 things you learned from the talk. I went. Credit. Quiz scores. Latest quiz, I will add 5 points. I'd like to have a quiz. I don't want. Okay, that's good. So questions? I know some of you may have clinical, other places perhaps. I don't know if 7 p.m. is going to be doable, but try your best. That's the only time he's talking. So, questions? Anything else that I should be remembering? Okay. So, in lab this week, we're going to be talking about cancer, figuring out absolute neutrophil count. So we'll walk through that together. And neutropenia, we'll do SIM. So not a huge new skill week, perhaps, but important to be able to identify people who are neutropenic. And yeah, next week we'll jump into EKGs, which I love, interpreting rhythm strips. So you'll be able to watch Grey's Anatomy, whatever show, and be like, wrong, or yay, they did that right. Actually, we're a VTAC, good job. Know how to treat those kind of dysrhythmias. So that's fun. And then we have NG2 still, we have blood transfusions. Is that all? Oh. Seems like a little short, but that's right. Chest tubes, NGs, blood transfusions, FATs. and cheese. Austin. Austin. That's exciting. Good job. Way there. Any questions about anything? What to expect? Okay, let's jump into care of the patient with cancer. So it seems a little bit crazy that we're just gonna be talking about cancer in a day. But that's what we're gonna do. So please read chapter, is it 13? This is, yeah, really important information. We're going to take care of patients with cancer, whether you're in peds, adult, older adult, you are going to see cancer. So let's just learn in general what it's all about. Maybe. Here's your learning outcomes. This is a good way to study for your test. Telling you this is my goal for you out of this lecture. This is what I want you to know. So if you can answer these questions in an application type manner, you'll probably do just fine. So these are references. Okay, so how would you define cancer? You had to find out, what would you say? Like, that's why I'm here. Lay it on me. Give it to me. Okay, all right. Uncontrolled cell growth and altered cell differentiation. The leading cause of death worldwide. We have increased incidence. So incidence versus prevalence. These are terms that I want you to know. Incidence and prevalence. You read that almost in every condition we talk about. So what is incidence? Number of new cases. So incidence is going up, and then prevalence, they say, is number of total cases. This will be important for you, probably for EVP too, right? Looking at incidence, prevalence, then also we look at morbidity. So that's injury, and mortality is death rates. So all these things are often talked about when we're talking about how prevalent do we see this. We see cancer a lot. So like we said, it's the leading cause of death worldwide, second leading cause of death in the US. And basically we have uncontrolled cell growth and altered cell differentiation. We'll talk about some of the characteristics here in a sec. How does it spread? So it depends on if we're talking about a solid tumor type mass, we're talking about cancer that's in the blood, or cancer that's in the lymph system or the bone marrow. So if it's in those areas, such as the blood, that's how it moves. It moves through the blood, so it's systematic. So from the head to the toe, right? Whereas a individual solid tumor is going to be spread from that source. Oftentimes, as it invades the good tissue around itself, it can get into the lymph system and then travel through that to various parts of the body, which we call metastasis, or in the bloodstream itself. Okay. What can we do as nurses? We're doing it right now, learning about it for one thing, but also how to prevent it. It's always what our goal is, right? And then how to treat and care for the patient well. That's what we're going to talk about here. Okay, so how often does cancer occur? So 78% of cases in the United States are found in older adults over 55. So we know as a person ages, their risk of cancer increases because of mutations in the cells, right? Genetic alterations that happen. And just as we get older, you have more chance of that happening. So it makes sense that we would see that as people age, but I don't want you to think that it does not affect children. It does. So the most common types of cancer in children are leukemias and brain tumors. Okay. Most common types of cancer globally lung cancer, breast cancer, colorectal cancer, stomach cancer, and prostate cancer. Talk about why that is here with the risk factors involved. For the US, I think for men, it's prostate, lung, and colorectal. Okay, and then women, breast, lung, and colorectal. So an interesting trend, sad interesting trend, is that we're seeing colorectal cancer in young people, your age. Yeah, I just said, like, usually happens as we get older, but we are seeing it now in your age. And not just colorectal hard one, and that sometimes it's not found until at stage 4. Not really curable at that time. Oftentimes it's metastasized beyond our ability to treat. So why is that? Why do you think that is? I don't know, but I just want to hear your ideas.
Do you think it's like the food we're eating, like how it's changed from like more processed from previously?
Yeah, I think that's a good place to start, something that we're ingesting, right? Either processed foods, more natural kind of foods, definitely. Yeah, what else? In the last, I don't know, 15 years, 10 years, what do you guys drink? I don't see anybody with one right now. Okay, maybe. I don't know, but all those like power drinks, energy drinks, I don't know. That's new. I'm not saying that there's a cause and effect. I'm just throwing ideas out there. I have no idea. I have no idea. But it is a new thing. Like we didn't used to have that before. Vaping. You know, we just have to look at why would we be seeing it in your demographic? What is new? Right? Might be a combination of things as most of these are, but just interesting to note. So, what are risk factors for cancer? Age, carcinogen exposure. So tell me about some common carcinogens. Things that cause cancer. What are carcinogens? Tobacco, right? So smoking or chew, vaping. Anything that has. Yeah, how many carcinogens are in tobacco smoke? Oh, 70 or something. My gosh, yeah. So let's steer clear of that if we can, right? What else? What are there other carcinogens?
Radiation.
Yeah, radiation. So that can be sunlight, UV radiation, or it can be medicinal radiation that we use for like X-rays. CTs. You're exposed to that a lot, or sadly, like nuclear weapons. Could also be a way to have that exposure. Asbestos would be another one that we see. And chronic inflammation, so we can see that in autoimmune disorders. Sugar, alcohol causes inflammation. Hormones, so we can see that's there's certain types of cancers that are specific to males or females. So we can see that hormonal presence. Obesity, immunosuppression, people who are on corticosteroids a lot, often with autoimmune diseases or with cancer treatment itself. Infectious agents, so tell me about that. What are some common infectious agents that would cause cancer? One that you get a vaccine for? HPV. HPV, yes, that has dramatically decreased, I think 68% in cervical cancers related to HPV vaccination. So 68% decrease is a huge decrease in that. Epstein-Barr would be another one. Hepatitis B is what I got for you all. Hepatitis C, both of those can cause cancer long-term. So you get a hepatitis B vaccine to prevent that. And H. pylori. You don't see that as much here in America, but around the world, H. pylori is the #1 cause of stomach cancer. Okay, contaminated water or food sources, and then radiation. Okay, and this is just a graph showing you the incidence, the prevalence of cancer, and as we age, how it increases here. Interesting that we have a little drop here. What do you think that's related to? Probably are dying from like infectious processes at that time. Okay, a local example. I don't know, do we have anybody from Libby? Sometimes we do. Okay, Libby, Montana is up kind of north. A beautiful, as you can see, this is a picture of it. Beautiful mountainous, very heavy timber industry. So back in the 1919s, they started vermiculite mining, which is used for construction equipment. I'm not sure what, but unfortunately, where there's vermiculite, there is asbestos. So they had vast numbers of exposure to asbestos and causing mesothelioma. I don't know if you see that on TV. Sometimes there's advertisements for like, if you lived in Libby during this time and have experienced these things, you may be able to participate in a trial case study, whatever. And sadly, it's because of mesothelioma. And huge numbers, 1 in 10 currently have an asbestos associated disease. That is, this is like an environmental carcinogenic exposure. All right, what can we do for health promotion and disease prevention related to cancer? Diet is important. Healthy body weights. Avoid smoking, you already told me that. Alcohol and tobacco use. Avoid risky lifestyle. So number of sexual partners, same-sex practices. Avoid environmental exposures when known, right? Breastfeed infants for the first 6 months. Interesting thing, right? You took care of the family, why would that be? Awesome. Yeah, passing on that immunity to those little babes, right? Physical activity. Yeah, we know that people who live a sedentary lifestyle are more at risk. Protection from UVA and UVB rays, so that's that radiation. Chemoprevention medications to disrupt cancer development. That's kind of a newer development for us. People that are at high risk or maybe in remission, we put on chemoprevention. It's not that they have an active disease happening, but it's medications to help prevent relapse. And then immunizations, like we just talked about, Hep B or HPV. Okay, so primary and secondary and tertiary prevention, you learned this last year. I will ask you it again. The difference between primary prevention, secondary, and tertiary. Tell me what primary prevention is.
Isn't it like preventative stuff? Like just making, like doing things to like try to prevent it from occurring.
Yeah, so everything we just mentioned on the previous slide, for all of us, that would benefit us, right? Like to watch our diet, lead an active lifestyle, avoid tobacco. Those are generalized things for the whole population to help prevent. That's primary prevention, right? Secondary prevention is where we actually are screening to identify people at most risk, especially those with family history. So looking for that. That could be through genetic counseling, but it oftentimes is just through reported family history. So this is where we see our mammogram screenings or colonoscopy screenings, fecal occult blood, pap smears, those kind of things, especially for people who are at risk. So when you think secondary, think screening. Primary, it's primarily good for all of us, right? And then tertiary is they actually have cancer. And now we're just trying to prevent further injury or death related to treatment. Okay, or the process itself. All right, so here's our little screening. There you go, mammogram, colonoscopy, fecal occult blood, rectal exams, and screenings for gene mutations. This is a mammogram. I don't know if any of you have had to have one of those yet. Not the most comfortable thing. They are squashing your boobs between two plates. And they are looking for tumors that you may not deal with. So we should be doing self-breast exams, but even this will pick up on those that you may not feel. Okay, so really important to encourage your patients to do this. What is the age that this should be started? Yeah, 40, especially if there's family history, 40. There's maybe 45. But 40 colonoscopies, this has been reduced. At risk, 40. Others can be at 50. You get the all clear where there's no polyps. You can wait 10 years to get another one, unless you have a family history. Fecal occult blood. So this is, what is this? Fecal occult blood. Do this in the hospital, but people can do this at home, where they take a little specimen of stool, like a little tongue compressor, I guess, and put it on this card. And then you have two little windows on the card. So you put stool on both sides of those and you have a developer. Sometimes they give you the developer, sometimes you're sending that to the lab for them to put the developer on. And then it's identifying blood in the stool. If you see blood, then we're calling you in for a colonoscopy. Okay, so fecal occult blood is often the first step to identifying colorectal cancer. In Montana, we have a huge rate of rectal colon cancer, probably related to diet and alcohol, tobacco use, sure, and not going in for screening. Like these independent fools. We're like, I don't need to do that. Like, we do. Everybody needs to be doing this, right? Yeah, so encouraging that for our patients will be really important to help prevent stage 4 colorectal cancer, right? And then screening for gene mutations. It's kind of where the future lies, I think, for you all. Okay, pathophys. Carcinogenesis is basically how cancer grows. So some things I want you to know are with multiple carcinogen exposures, we have cell mutations that the immune system fails to recognize. So it proliferates, as you can see, progresses into cancer. In certain characteristics, we have this uncontrolled cell growth, lack contact inhibition. So this is interesting. Most of our cells, when they come in contact with other cells, stop growing or stop replicating. Not with cancer. That's turned off. We don't have that suppressor cell happening. They do not undergo apoptosis. That means each cell kind of has a regular kind of life cycle. So when they get damaged, I don't know, like I think of red blood cells, I think they have a cell life of about 4 months. So after 4 months, they have programmed cell death. Basically what we lose, we produce, but that does not happen with cancer cells. They do not die. They're like immortal little cells, even when they're damaged, and then they proliferate. Okay. No anchorage dependence. That means usually most of our cells sit on like a basement membrane and have a source of oxygen coming through blood, right? So their own blood source. Cancer cells don't need that. So they can grow wherever. And oftentimes blood sources will grow around them. That's crazy. Right? So many rules that we know that pertain to normal cells do not pertain to cancer cells. And then we have these terms, neoplasia, uncontrolled cell proliferation, anaplasia, when a cell loses expected structure and function. Dysplasia, different cell types. So that's one way we can classify cancer is by saying if it's well differentiated, it looks similar to the parent cell that it came from, or if it's poorly differentiated, it doesn't look anything like the parent cell. This is an important part in grading tumors. Okay, so oftentimes when we see dysplasia, so we see different kind of cell types in an area, doesn't mean they necessarily have cancer, but they could be at risk for developing cancer. So when we see polyps in the colon, that's dysplasia. Cancer cells replicate and expand locally into malignant tumors, yes, or we can have it travel through the lymphatic system, like I mentioned, or through the blood. So that's metastasis. It starts in one area and then it spreads to another area. That could be very localized from that solid tumor formation, or it could be that it gets into the bloodstream and travels throughout the body, or through the lymphatic system. I think one of the common sites of metastasis for breast cancer is lymph nodes, yes, and then travels through the lymphatic system. Also brain is a common one, also get into the blood system, so then we can see it in the liver. So it can be very localized to this area, or it can be throughout. And we have to identify, is that the primary tumor, or is that a metastasized tumor? Okay, so you're looking for that parent identification. So you can have like prostate cancer, but find it in the liver. You know that the primary source is prostate. It's metastasized. Okay, may remain molecularly similar to the original tumor. That's primary tumor, or secondary metastatic tumor is somewhere else in the bone. This is just a visual example of, we got normal cells. We got our little cancer cells here, lymph cells, blood vessels. So the cancer cells in the primary site, and then they evade into this tissue, into the bloodstream, and then travel, transported to distant sites, either through the lymph or blood. And then they reinvade and grow at a new location. Types of cancer. So I want you to know that we can have solid tumors or we can have hematological malignancies, which solid tumors can appear anywhere in the body. Hematological, we're talking about leukemia, lymphoma, or multiple myeloma. And we'll talk about those further here in a sec. And then further classified by organ or system of origin. Basically, leukemias affect blood cells, leukocytes, and lymphoma affects lymphatic system. So that can be throughout the thymus, spleen, throughout the whole lymphatic system. And the multiple myeloma is affecting plasma cells or immunoglobulins. All right, so staging is how we determine kind of the size, whether there's lymph nodes involved or whether there's metastasis involved. So you'll see T and M. T is tumor size, and it can go TX through T4. N is lymph nodes involved, so NX through N3, and then presence of metastasis. MX is not, you can't know, unknown. And then MO, no metastasis, M1 is metastasis. NX, same thing, it's unclear. And then N0, nothing, N1, one node, and two nodes and three multiple nodes. Okay, that can be very localized or it can be spread out, and then tumor size, T4 being the largest. T0, they call it in situ, INSITU, it's very localized. Often that's TX actually. And then grading, this is where we're talking whether the cells are differentiated or undifferentiated. Okay, so do they look like the parent cell or do they look totally different? So that's GX through G3. This is staging. So you can see stage 1 is a small tumor without obvious spread outside the organ. Here we go. Stage 2, invasion of the tissues or involvement of local lymph nodes. You can see that right here. Local or stage 3, large or locally invasive tumors. It's getting beyond the borders here into the lymphatic system as well, much larger. And then stage 4, cancers that have metastasized. So we find them in other areas of the body. So you'll hear them say the staging, they'll talk about the TNM, talk about differentiation. All hematological, so leukemias, lymphomas are stage 4 because of the total involvement and lack of localization. So it's throughout the lymph system. Bone marrow. Okay, so clinical presentation. I want you to know there are different types of symptoms, signs that we may see in our patients. So you've learned caution before, I think, in assessment, right? So this is review. Remember this? You're asking your patient if they notice any change in bowel or bladder habits. That could indicate colorectal, bladder, renal issues, a sore that does not heal, unusual bleeding or discharge, thickening or lump in the breast or any other part of the body, indigestion or difficulty swallowing, so dysphagia or them saying they have a lot of reflux, obvious change in a wart or mole, and then a nagging cough or hoarseness. So they may tell you that, or you may notice it as they're talking to you. You notice that they are hoarse or that they're coughing. You're like, oh, how long have you had that? They say like, oh, I don't know, 4 months. I would first look at their medication list, see if they're on an ACE inhibitor, and then I would be like, tell me more about that. Have you noticed anything else? And if they say constitutional signs such as unintended weight loss, night sweats, unintentional weight loss, night sweats, unexplained fever, or fatigue. Yeah, still kind of vague symptoms, but in association with these caution symptoms, you should be looking further into that. Yeah, fever of unknown origin, night sweats, fatigue, and significant weight loss, unexpected, or constitutional signs. In pediatric populations, same things can happen. Fatigue. So like an active little 6-year-old doesn't have much energy. This is beyond like maybe a cold. Longer duration. Easily bruising. We often see with leukemia, bleeding and bruising. So you're like, gosh, you barely hit your little shin. Had a huge bruise. That might get your attention. And of course, night sweats, weight loss, or lack of appetite. Little babes. And then malignancy specific signs and symptoms. That's related to the location of the primary cancer. So we can have that solid tumor where it compresses and involves the surrounding tissue. If you have a big old tumor in your esophagus, you might have people complain of dysphagia, have that weight loss. It extends beyond that area. May impact their breathing. You know, just in the location that it's at. Don't vote for me. All right, so diagnosing cancer, we can do our initial assessment. So you're looking for all those signs and symptoms we just mentioned, doing your head to toe. But then we can do diagnostic tests. So we can actually do tumor marker assays. So that's a blood test. We can do biopsies where we can take a needle and remove a portion of the tumor to identify it. We can also take lymph nodes for biopsy as well. Genetic testing can be done, especially if you know that there's family history. Genetic tests like the BRCA gene, very common one now for breast cancer and other types of cancer, actually, not just breast cancer. Laboratory studies. That's where we could get a CBC for people with leukemia or lymphomas. We'd be looking at their blood counts. And then imaging studies, so a CT, MRI, X-ray, or ultrasound. This is a picture of bronchoscopy, so if we're worried about something down here in the lung, this is just a little flexible tube that has a camera on the end. So this is the thing I was talking about when we were talking about choking. They can go in and actually remove, I don't know, the penny that the person swallowed, but they also use it for obtaining biopsies. Okay, and then this is an example of a PET scan. So a PET scan is a radiological exam where we give you usually contrast, but we have you withhold glucose because PET scans pick up high metabolic areas. So that's why you see the bladder highlighted in this area. It doesn't mean that they have cancer there, but these are what you're looking for, these hot spots. And glucose tends to hold on to what we use. We usually have them limit their glucose intake for this test. And then you're looking for this. This is an indication of the test. Not a good finding. And then endoscopy, like our colonoscopies or upper endoscopies, bronchoscopy. All right, so treatment goals. If it's not curable, the goal would be to reduce the tumor burden or prevent progression. So we're always trying to work for cure when possible. But if that's not possible, then we're working for remission. So remission means that we don't have any evidence of the cancer being there. So a disease-free state. We don't know if this will remain that way. Sometimes people say they were in remission for 3 years and it came back, or they've been in remission for 6 years. No indication of the underlying cancer. It's a good thing. Palliation is cancer that's not curable. So we kind of treat the symptoms. So basically alleviating symptoms of the cancer. So if it's a tumor that we can't remove, then we can shrink it with radiation to at least not have difficulty swallowing or have pain. So we're not working towards cure, we're just trying symptom management. Okay. Should be patient-centered in collaboration with the patient. So asking them their wishes, but they have to understand these terms as well as the disease process that we're talking about. Right? Help them be able to come up with goals, and of course they may change as things go on, but should be collaborative and patient. The 3 broad treatment modalities are: we can do surgical procedures such as removing the tumor or at least reducing its size. Sometimes we can't take it fully out because of where it's located, but we try to take as much as we can. Or tumor excision is the whole thing. The whole thing is removed. So that's awesome. If we can do that, that's a good thing. Radiation therapies, this can be localized or systemic. So anybody have any experience with radiation? Have you seen this in any of your clinical? So it can be like an external beam type thing, like a laser type beam, where you get marked wherever we're targeting. And they have to line it up just perfectly because it is hitting that area exactly. So you can't have the patient move, or we can't be off, even like a little millimeter. It has to be exactly precise. So you'll see them get marked with like kind of looks like tattoos for the moment, to ensure that we're hitting the targeted area. It also can be systemic, where we just give it throughout the body. So something like an IV radiation. It also can be very localized, such as seeds, radioactive seeds that we put in to like for prostate cancer. So I had a gentleman in Seattle when I worked out there who had prostate cancer, but I did not get that in report. He's in the ICU for something else. And I had just found out that I was pregnant with my first baby. But no one knew that because I hadn't said that. So I was in taking care of the patient, you know, doing my little head to toe on him. And thankfully he was alert and oriented and could talk to me and said something like, I wonder, I don't know, something about the seeds. And I was like, what? Like, yeah, I just got in place yesterday. I'm like, oh, okay. As I moved away from him, being like, what in the world? So we have to make sure like we are telling our people whether you think they might be pregnant or not, because you wouldn't want anything to be around in that short amount of time, like an hour is not going to do something, but like a 12-hour shift, yeah, don't want to take any chances. So just let people know that you can't see them. They're inside, they're internal. I'd have no way of knowing unless you said something. So just kind of be thinking about that for protecting yourself and your coworkers, right? And then family members too, give them education on how to keep their family safe. They are radioactive. Medical treatments, so anti-neoplastic therapies. So this can be chemotherapies, immunotherapies, and targeted agents. So it used to be that we just had chemotherapy, you guys, and that was so hard. It would just destroy all cells, not just cancer cells, all good cells. And people were very, very sick. They still can be very sick, but we were much better than we were with chemotherapy. And now we have immunotherapies where we have their own body cells attack the cancer tumor. And that has been like a game changer. Targeted agents, same thing, like really targeting the specific like cellular structure rather than just this systemic chemotherapy. So we can use single therapy or multimodality. So we might have to use radiation before we can do surgical intervention, followed by chemotherapy. So it can have multi modes, or it can just be, maybe they just need tumor removed. No chemotherapy, no radiation. Neoadjunctive therapy is where we shrink the tumor before surgical incision. Adjuvant therapy is treatment on a patient who is currently disease-free or in remission, but at high risk for relapse. That's where that chemo prevention medication can come in to effect. All right, so chemotherapy we can give topically. I've never done this. I didn't work per se in oncology, so I don't even know what that looks like. A topical chemotherapy. Okay, oral, parenteral, so anything IM, IV, intra-arterial, intraventricular, intracavitary, holy moly, intravesicular, intrapleural, and intrathecal. So all areas of the body, it sounds like we can place chemotherapy. If you're working in oncology, you have to protect yourself. So to inhale chemotherapy agents, so pharmacy and nurses have to be mindful of this. If you're mixing chemotherapy, it has to be in a special kind of room that you're not breathing in that chemotherapy because it's carcinogenic or teratogenic. So protecting yourself. So that might mean wearing double nitrile gloves. It used to be that we have chemotherapy gloves. They kind of look like your big kitchen gloves when you're cleaning your oven or something. But now they're saying 2 of the nitrile gloves is just as good. You want a fluid permeable gown so that if it spilled on you, it would not go through the gown. And then again about inhalation. So wearing PPE, we usually have the patients flush the toilet twice because their bodily fluids will be contaminated as well. So be mindful of that when you're cleaning someone who might be incontinent, like how you're going to contain that. You usually double bag it into the biohazard linen so that the people in laundry know it's contaminated. Okay, so it's not just us, but it's people along the line caring for the patient, trying to keep everybody safe. All right, so complications that can happen, I'm sure you're aware of many of these: nausea, vomiting, anorexia, so weight loss or lack of appetite, alopecia, where people lose their hair, that can be very challenging for just identity. You're already feeling horrible, and then you don't look like yourself, and it can be really, really hard. Immunosuppression, so neutropenia, we're going to talk about that in lab, where these people will not be able to fight against infection. They have no white blood cells per se, fight any kind of pathogen that might come their way. So this is when we put them on neutropenic precautions or protective isolation. Mucositis, stomatitis, issues with their mouth. They can get mouth sores. They can get like thrush, or they can get fungal infection. They can get xerostoma, where their mouth gets so dry, and like lozenges to keep their mouth moist, or little swabs that we can offer. And anemia is very common, and thrombocytopenia is for bleeding. Different treatment options include ablation therapy, radiation types. So here's our brachytherapy. Here, little radioactive seeds in that prostate. External beam, we just talked about that, or a systemic injection. So that goes through an IV. Hormonal therapies, these are, based all on different hormones, depending on what type of cancer we're talking about. And then immunotherapies, interleukins and interferons, they're usually given IV. Cancer Treatment Center, I know some of you guys have been there. Have you given, did you see them give this stuff? Yeah, pretty common to see immunotherapies now. Probably depends on the cancers that you're seeing. And then supportive therapy, also always want to be looking at the holistic picture. So spiritual care and psychosocial care, what kind of things are you going to be looking for? How could a cancer diagnosis affect someone's spiritual feeling? Right, yeah, that spiritual distress that can happen, right? Of like, why me? Why is this happening to me? You know? Or faced with mortality. We all know we're gonna die. But when you get a cancer diagnosis, I think that brings it to the attention of like, oh my gosh, am I going to die? Like, that's a pretty heavy thing to like face. But being able to talk with our patients about that. Cancer doesn't automatically mean a death sentence, but I think a lot of people think that when they hear those words. So helping our patients with that, then psychosocial care, that emotional response, as well as like family, affect the whole, their friends, their family, their ability to get out, their ability to work, the whole thing, Never lose sight of the holistic care. All right, these are ones I want you to know. So star these on oncological emergencies. So this can happen because of the tumor itself or what kind of cancer we're dealing with. That also can be related to our treatment. So bowel obstruction can occur if we got tumors sitting in our colon or any part of our bowels. So we want to be looking for that. How would you know if someone has a bowel obstruction? Yeah, abdomen might be distended, good. What are you gonna say, Paige?
Like discomfort or pain.
Yeah, discomfort, distension. Maybe they haven't had a bowel movement in how many days, or you're like, are we talking constipation? Or are we talking about obstruction? What do you think it sounds like when you listen to bowel tones above an obstruction? What do you think it sounds like? Above? We got things happening. Like. You like, but then when I go below, I hear nothing. That could be a good indication. This is an obstruction. Would I continue to feed someone if I'm worried about an obstruction? No, might be someone that requires TPN, which is nutrition through their IV. Okay, we're not gonna use the bowel, perhaps. Hypercalcemia is another complication. You have a lot of electrolyte issues, but hypercalcemia is a very common one. You're gonna have hypophosphatemia and hypercalcemia. What kind of signs and symptoms might you see with hypercalcemia? Think back to our electrolyte earlier. Oh, nerve function is going to be affected, right? They can have those paresthesias. Oh, they're like, gosh, I feel like my hands are like numb. About kidney stones developing because of hypercalcemia. Yeah. Syndrome of inappropriate antidiuretic hormone. This is something you'll learn about next year. Basically, you have fluid overload happening, so you can have hyponatremia occurring. Basically, you have too much ADH happening. And we just have to watch for the sodium complications and get rid of the extra fluid for them. Let's see. Yeah, so they're on fluid restriction. Get rid of that with diuretics, watch their sodium. Okay. Hypercalcemia is most common with metastasis to bones. That makes sense. Superior vena cava syndrome, that's compression of the superior vena cava, so that reduces blood flow to the heart. And we have venous congestion occur. Spinal cord compression, that's if the tumor is right up against the spinal cord. So people might have new numbness, loss of feeling, or loss of bowel or bladder. That would be a concerning finding. Hematological disorders, leukostasis, anemia, and disseminated intravascular coagulation. You can have all blood cells affected, not just red blood cells, white blood cells, platelets as well. Tumor lysis syndrome, this is interesting, usually related to treatment, where the tumor is breaking down so quickly that you have not only remnants of the tumor, but also changes in your electrolytes. You can have hyperkalemia, which could lead to requiring dialysis. Just most common in rapidly proliferating tumors, like leukemia and lymphoma, or therapy-sensitive tumors, where they are lysine cells accumulating, causing electrolyte imbalances and renal dysfunction. We have low calcium, high phos, high potassium. Okay, tumor lysis, breaking down too quickly. All right, neutropenic fever is one I want us to think about. This is what we're going to talk about in lab, where we're calculating this ANC, absolute neutrophil count. This is characterized by an ANC less than 1,000, and where we see a temperature of 101 or 100.4 for more than 1 hour. So neutrophils, we're kind of following their CBC with differential. So we look at a CBC, we can actually break it down into the different types of white blood cells. So we're looking at these little neutrophils. And they're susceptible to like chemotherapies or cytotoxic effects of chemotherapy. Risk factors include high tumor burden or extensive disease, so large tumors or metastasis, current chemo and radiation treatments at the same time, and type and dose of chemo. So basically, these people have no neutrophils, which is our #1 kind of fighters against infection, right? So we put them on protective isolation. Remind me what that is, also called neutropenic precautions. It's protective isolation. It's one that's different than all the others, and that it's not that they have something that we're trying to prevent the spread of. We're trying to
like prevent bringing stuff into them, and so they have like the negative pressure rooms, so their ventilation is attached to the rest.
Great, yes, good, so they're having their own airflow. Good, awesome, trying to protect them from all organisms coming to them.
It's not like you can't bring fresh flowers or
Yeah.
bring fruit.
Right, how come? That's right,
Microorganisms.
yeah, little organisms that are on our fresh fruit and vegetables, right? Like, is it Pseudomonas that's in the, like, flower water, you know how it gets kind of mucky, murky? And a funky smell, a lot of times that's Pseudomonas, so we don't want to expose them to that. So no fresh flowers, oh yeah, remember, no sushi. And if we're doing fresh vegetables, it has to be something that's peeled. Like an orange or a banana, actually. Take off the outside cover. But most things are just cooked. We're just trying to prevent any pathogens, should anyone who's sick or possibly be sick walking into that patient's room. No, so we actually limit children from coming in because they're little germ carriers, right? So anybody under 12 usually is not allowed on someone's room who is neutropenic. Again, you can see how their social interaction can be affected, right? So when I was, this is neutropenic, signs and symptoms. So they might have fevers, rigors, chills, diaphoresis, hypotension, tachypnea, and tachycardia. You can see changes in their albumin, bicarb, C-reactive protein, that's an inflammatory marker, and procalcitonin, depending upon what kind of tumor we're talking about. Management, we're gonna get cultures, so urine, sputum, blood, chest x-ray, start antibiotics after getting your cultures, IV fluids, manage their temperature, but most importantly, prevent this from happening. So you're doing precautions. A couple years back when we were on, did I tell you this story? I may have told you this story. We were on the oncology floor and one of the students was taking care of this gentleman who had, I'm not sure what type of cancer. I was talking to our CRN, who was a Carroll grad, and we were just chit chatting, and the student walked by going to get like a blanket from the blanket warmer. And CRN was like, "Oh, who are you getting that for?" And like, "Oh, Mr. Jones in room, blah, blah, blah." And she was like, "Okay, how come?" She's like, "Oh, he just said he's kind of cold." She's like, "Okay, I want you to go back in there. I want you to do a full set of vitals." And the student's like, "Oh, I just did." And Brucey's like, "I want you to do it again." She's like, "Okay." So she went in and took it, and his temp was 100.4. Heart rate, vital signs were okay. But Reese's like, "All right, we're drawing cultures, drawing everything." And this is a person who was up, walking, talking, sitting in his chair, seemed pretty stable from an outside perspective. I talked to Reese later. They ended up flying that gentleman out. He became septic within those 12 hours. So that little hint of like, "Oh, I'm just a little bit cold, a little chill, kind of temperature," like he was lead into this, and he was neutropenic, like he had just finished chemotherapy. His ANC was less than, I think it was like 500. So that poor guy got flown to Salt Lake. So it can happen like that, picking up on subtle little things that to us maybe we're like, oh, well, I'm just gonna do a nice thing, get a blanket because he's chilly. Like, getting an infection, he doesn't have any way to fight it, so he can die. It's the worst thing that can happen to him. Right, so picking up on these symptoms and preventing it altogether. Okay. So, nursing management, care of patients with cancer, crosses all subspecialties of medical surgical nursing and ambulatory primary care. Okay, so you tell me who might be involved with caring for an oncology patient. Definitely is interprofessional. Who is going to be part of the team? Us.
Like, they're on this.
Yeah, so oncology is gonna be leading the charge on how we're treating this, right? But we may need the assistance from surgeon, if we're doing excision, right? Yeah,
Dietitian.
dietitian, absolutely, like increasing that protein, vitamin C. For women, really important. They can't swallow, they can,
Like a therapist.
yeah, therapy, so if we're any kind of physical therapy, occupational therapy may be needed. Okay, going.
Especially for diagnosis, like primary care.
Right, so primary care follow-up, right, they're gonna be seeing their patient, you have to understand what the plan is for this oncology picture, but it doesn't mean all other things stop. Right, they may have other conditions happening. So that primary care provider being involved in that care. Possibly home health might be needed. Chaplains, spiritual side of things, maybe psychologists or counselors as well. Okay. And can you manage in a variety of clinical settings? So many of you are seeing outpatient clinical or cancer treatment, right? In the cancer treatment center. But then people can also be on oncology floor. Okay, so possible nursing diagnoses. Tell me. If I was like, all of these would apply to a patient with cancer, true or false? Lay them on you. Yeah,
Imbalanced nutrition.
yeah, absolutely. Less than body requirements, perhaps. Yeah. Ms. Bone, what were you saying? Were you saying something? Oh, sorry, I thought you were. Okay. Give me another one. Yeah, risk for infection, absolutely, right? Yep. Going.
Ineffective activity tolerance.
Good, good. Good. Yes, absolutely, right. Good. Ineffective coping, perhaps. Anticipatory grieving, perhaps. Altered respiratory pattern, altered.
Didn't say altered body image.
Yeah, yes. Where sometimes you have to do significant changes in the patient's body and function. Right? Ostomies for colon cancer, mastectomies for breast cancer, major life changing surgeries. How to do inadequate nutrition, altered elimination, ineffective coping, spiritual distress, altered sexuality, altered fluid volume excess or deficit, pain, ineffective breathing pattern. Many. Okay, blood neoplasms. Let's talk leukemia really quick. So this is where we have cancers of the white blood cells. I want you to remember that acute lymphocytic leukemia, I think we have a little. Yeah, okay. White blood cells are not functional and they invade and destroy the bone marrow. Okay, there's these different types. We have acute lymphocytic leukemia, we have acute myelogenous leukemia, or we have chronic. So you can see we have acute or chronic. And we can be dealing with the lymphocytes themselves or myelogenous. What do you think myelogenous means? Yes. So this is like plasma cells, stem cells in the bone marrow, where lymphocytes are your white blood cells. So it can be acute or chronic. These 4 different types. So acute lymphoblastic leukemia found in lymphoid cells grows quickly. This is common in children. There's about 6,000 cases a year. What it looks like under the microscopes. Acute myelogenous found in myeloid cells. So again, plasma or stem cells grows quickly, common in adults and children. You can see 18,000 cases a year. Chronic lymphoblastic found in lymphoid cells grows slowly, most often in our older adult. And chronic myelogenous leukemia, not as common, only 6,000 cases per year, grows very slowly. All right, so some of the signs and symptoms that the patient may present with is bone pain. That's unusual. Unless you have hurt your bone, to have bone pain is unusual. But that would be something that I would be like, oh, tell me more about that. Joint swelling, that can happen with some of our autoimmune diseases, or of course injury, but if it's without any of that, that would be concerning. An enlarged liver or spleen, so that could tell me like, oh, we're talking about something within the blood. Little spleen filters all our little like blood cells, red blood cells are coming through. So that would be concerning as well. If I saw an enlarged liver, weight loss, fever, remember constitutional signs, poor wound healing, manifestations of anemia, so fatigue, pallor, maybe shortness of breath, if we're talking severe anemia, and then evidence of bleeding. So we're going to draw this CBC. We're going to calculate ANC. You're going to be looking for low red blood cells, hemoglobin, and hematocrit. So that's anemia. Decreased platelets, thrombocytopenia, decreased white blood cells, and immature white blood cells. You will see all these immature little neutrophils out there trying to fight off whatever's happening. We used to call that a shift to the left, but basically it just means like something new is happening. Could be infectious, or it could be an indication of cancer. In the setting of all this, like, oh, probably talking about leukemia. Coagulation studies, liver function, kidney function, lumbar puncture. If there's CNS involvement, we're going to check their cerebrospinal fluid. Then the bone marrow biopsy, kind of the gold standard where you would look for immature leukemic blast cells and protein markers, which you have identified specific to leukemia. That's something relatively new in the last 20 years. CT, MRI as well. Okay, this is just a visual image of our little pediatric patient. So ALL is the most common type. If you saw a little one who had bleeding, coagulation issues, bruising, like I said, they barely touch themselves and they're bruising, or just multiple bruises throughout the body. Lymphadenopathy, what is that? Like touching all their lymph nodes, they're like enlarged, maybe not painful, but enlarged. What is happening? Have you had a cold lately? No? You know, all these bruises, infection, fever, and then bone pain. That's so unusual, right? Okay, lymphoma, really quickly, is cancer of the lymphocytes. Specific blood cell, white blood cell. There's 2 types I want you to know, Hodgkin's lymphoma and non-Hodgkin's lymphoma. How they differentiate between the two, because sometimes it's hard to tell unless you see it under the microscope. They're looking for, and the NCLEX asks this question, like, how do you differentiate between Hodgkin's and non-Hodgkin's lymphoma? It is the presence of Reed-Sternberg cells. Okay, so these are like, see these little, it's supposed to look like an owl. Those look like owl eyes. That's what they're looking for, Reed-Sternberg cells. When they see that compared to this normal lymphocyte, they know that you have Hodgkin's lymphoma. Thankfully, it is one of the most curable types of cancer. Non-Hodgkin's lymphoma, sadly, is not. It's important to be able to tell the difference. Know what that means if I say that on a test. They will present with enlarged lymph nodes, perhaps fever, weight loss, fatigue, infections, and night sweats. So a lot of those constitutional vague symptoms. Enlarged lymph nodes is specific to lymphoma. We would do a CBC, CT, biopsy of the lymph nodes. Okay, chemotherapy. Quality stimulating medications. That's kind of like our erythropoietin. Immunotherapies, radiation, and stem cell transplant. What can cure them? Nursing, that's kind of important, yeah. Prevention of infection, prevent injury, conserve energy, monitor for complications, so pancytopenia, what is that? Pancytopenia. Is what we just talked about, so if everything is low, your red blood cells are low, your white blood cells are low, your platelets are low, we call that pancytopenia. We have to be watching for bleeding, we have to be watching for infection, and we have to be watching for the effects of anemia. Hypoxia secondary to anemia, complications of chemotherapy, like mentioned, and then graft versus host disease. So if they get a stem cell transplant, they can reject those cells. That's why we want everyone to like do a little saliva and get your bone marrow kind of in this, what is it called? Like some sort of bank that when people need stem cell transplant, they can look for a donor. Not people.
But you can do that.
John, I will see you. Are you
Yeah.
Come on, they kept talking about it, I'm like, come on, when can I, like, when can we say that this is happening, but I never did. I never really touched them. Program. Okay,
I don't have to work for them, but I'd like to,
yeah, I mean,
maybe right now.
yes.
If they have the pediatric. It's a lot when I was there, so,
That, yes, like, that's a win-win,
Yeah.
absolutely.
and it's close to my sister and her husband live in Alberta. Canada.
Okay, yeah,
And so it's closer to them than here,
yes.
and we just had another little baby, so. I'm like, I would like to be close to them, because I know they're gonna keep having kids, so.
And I think like Benefis is here, so is
Mhm.
Benefis in other areas?
As of right now, they just have monthly locations, they have some like areas that are more rural, they're just
Yeah.
like clinics. And then they have obviously the surgery center here. and, like,
Those ones are super, the critical access.
Uh-huh.
Yeah.
Yeah,
Yeah, like state.
my dad was like, maybe they'll put one in Great Falls, or in Missoula,
Oh, they might,
yeah,
though there's a lot of competition.
I know,
Right,
and that's why I
like-
was like, maybe, but.
I mean, they came here,
So.
which, I mean.
Missoula,
Yeah.
Yeah.
I think that's a really good option, you know, just take the stress.
Yeah.
You know.
I don't think I'm like not worried about how I'm gonna pay for school for like 3 years.
You know, I was like, come on, come on, yeah, I thought, yeah. I thought we had a good idea, yeah. Office of Institutional Which deals. Her family had wanted to start something, you know, but. So. I was like, oh, okay. Yeah. She's like, I'm still working, I'm like, okay. So it would have been perfect, but I'm thankful for it.
Just wanna let you know
Yeah,
that
good
it
job.
worked out and
Good job,
talked with them.
good job, Christine.
I'm excited about it too, like I don't feel like
yeah,
I'm like
like you're like
just
being-
doing it so that I can get the money, like
Right.
I'm excited about. It's really
Yes.
with them.
And it kind of takes, not that you. At all. But you know, just kind of being like, well, I think I have a really good option, being
Yeah.
like, little foot in the door already.
Well, and they're kind of like St. Pete's, and like if they get a student applicant, they're like,
Yes, yes,
So-
they have been very, very gracious, which has not always been the case because they had their own nursing program there. So we never used to go there.
Yeah.
Like this is only since,
I think it's like this last year.
I'm trying to think like at. 20 years ago, and they were like, it's not a question of if you can be here, you always can be here. We're like, oh my gosh, okay, it was such a like. Just a refresh, just, yeah, just so nice to be like, yes, not a question of it, you are going to be here, you just let us know when you need to be here, what days, and we'll make it happen. But it benefits them too, I mean, it's mutually beneficial, so
Yeah.
like, we can't have a program without clinical sites, they need nurses.
Yeah.
And so they're like, we want your nurse. Okay, then, we should be able to make something happen.
Yeah,
So it has been a very good. Partnership for us.
and they're like. The exact amount of money that I need for next year is
Seriously.
the loan. So. Yeah. Like nothing else from out of pocket.
How did you do this? I was worried about this semester.
Well, I
This
got
was the.
a donor. Like an anonymous donor. It just like popped up in my account and I was like. Okay. Thank you, I needed that.
Yes,
So,
thank you, oh my gosh, oh
yeah,
my gosh, that's awesome.
yeah, so then I was only paying like, I think. 600 out of pocket, which is very doable for me, cause I have a job. So,
Yes.
And it was like, it was split up. So it wasn't like 600 in one, which would have been a little bit more.
Right, right.
But
Just spread out. Good job, good job.
Yeah. But thank you, I wanted to thank you.
I
because
didn't
you
do
sent it
anything,
to
I was
me.
like.
No,
"Okay."
no,
Like, I really got the. Meredith one, but I was like, okay, Lord, whatever's supposed to happen, like, but look, see, let's put the word out there.
and like, it's all like. I don't know, it's like, it's all felt kind of peaceful, cause like, it's a big decision to make, like, do I want to potentially commit myself 4 years somewhere? But, like, I'm closer to them, my family, I'm able to pay for the last year of school with no like burden on me,
Right.
so I can just save
And
money.
And like you said, not that you feel like you're tied into something, like, it's not like you're stressed over. It's like, that would be a good little plan, especially on Little Pete's floor, if they have something open.
Yeah.
Which, you know, we don't know here, so that's. Oh, that seems, I
We'll
just have
see.
to believe, like, always it's.
And
it's the
you-
plan.
You know, you can transfer too, so you can like, I can do my first year, like if I went in and did med surge.
Oh, yeah.
And then you can transfer departments and transfer locations and it doesn't affect anything.
Right, cause it's all within.
Cause it's
the
all
system.
benefits.
Yeah, that's awesome.
So I don't have to like choose a specific thing that I have to be
Especially if you're
committed
like,
to.
I wanted to do Pete's, but they don't have anything in Pete's, or maybe, you know, I have no idea, but. Yeah, that's awesome.
And I could leave after like 3 years if I
Yes,
wanted to.
yes, and be
just
like-
pay back 1 year
Yes.
alone instead of
Yes, which is totally doable when you're making money.
when you're making money.
You're like, trying to pay for school. You
Yeah,
know what I mean? So
Yeah.
that's totally,
and it gives me a chance to pay off my student loans
Yes.
without paying off both,
yes.
so.
Seriously.
Well, I just wanted to tell you, cause I know you sent it to me and.
Yes, I was like, oh my
Like,
gosh.
give you a-
I was like, we can, oh, sorry, Dr. Swamp said like, okay, we can start, like, can we send this to students? Can we let students know this? Cause I don't even think they had like put out their little
No.
flyer thing, and I was like, I know someone that could that could benefit from this. She's like, yeah, you can. I was like, okay, I'm doing it.
Well, cause I know like you sent it to me and then like a week later, it was in President Seck's newsletter and I
Yes.
was like, that's crazy.